Welcome, everyone. It's so nice to have you here on a Saturday morning. Um, so glad that we can talk about these things in an open and honest manner and to have such fantastic panelists here. So thank you so much for joining. I'm gonna let you know a little bit about how this all came about as people still start filtering in here for the next couple of minutes. I'm going to introduce myself. I'm Valerie Shelley. I am Senior Project Manager at Access Health International, and I'll be moderating this session today. I want to let you know a little bit first and foremost about WINGS. WINGS is an organization that empowers women to age well by staying healthy, being financially secure, and staying socially engaged. WINGS was established in 2007 as a nonprofit focused on helping women through their later years by providing education and activities focused on 3 pillars of health: physical and emotional health, financial security, and forming meaningful relationships with the community. So Access Health and WINGS have benefited from a very wonderful collaboration for the last couple of years. So we are quite happy to keep that going with this series of webinars. Access Health is a nonprofit global advisory think tank. And we are an American organization that operates in Singapore as well as other locations in Asia. And our mission and vision is to bring healthcare to everyone, despite socioeconomic status, age, gender, religion, in an affordable, high quality way. So we take part in ventures that do this, that are true to the mission. And this collaboration with WINGS, as well as past ones, aligns very well with that, as we are quite interested in looking at women specifically and their physical, emotional, and mental health in the Southeast Asia region. So I would like to now introduce our amazing speakers today. We have 3 wonderful women that will be speaking on various topics on menopause. Each of them is specialized in their own areas, but have vast amounts of experience and wisdom to share with us. So we're quite excited to hear from them from multiple perspectives. First, I'd like to introduce Dr. Rukshini. Dr. Rukshini Puvanandran, Senior Consultant and Assistant Professor at KK Women's and Children's Hospital. Thank you for coming, Dr. Rukshini. We also have Dr. Chua Tse-un, Senior Consultant and Head of Women's Mental Health Service, Department of Psychological Medicine at KK Women's and Children's Hospital. And we've got Dincy Lim, Founder and President of Women to Women Menopause Support Group, KK Women and Children's Hospital. Thank you all so much for being here. We are quite excited to hear from you. Before I pass it to Dr. Rukshini, I want to remind everyone that at the very end, we will have about 15 minutes of question and answer. And this is going to be a very valuable time to glean information from our panelists. So please feel free to put your questions in the chat box or the Q&A box. That's fine as well. And we will do our best to pass to the panelists and or be able to answer your questions in another way. But let's get the conversation going. Let's talk about the things that we need to talk about that you don't get to talk about at your in your normal lives. So I'd like to now pass it to Dr. Rukshini.
Thank you, Valerie, for the kind introduction, and thank you to WINGS and Access Health for inviting me today for this third in the series of Women at 40. I'm going to share my screen now. Okay, Valerie, can you, is the share screen on? Can you see? Okay. Okay, can you all see my slides? Great, thank you. Okay, I just want to introduce myself. I'm Rukshini. I'm a senior consultant in KK Hospital. I work in the KK Women Menopause Unit and the Family Medicine Service. So I do see a lot of women who come in during the menopause transition. And I'm going to be discussing the physical aspects of menopause. And I think later Dr. Chua is going to be speaking more on the mental aspect and the emotional aspect of this very, very important time in a woman's life. Okay, so the overview of my presentation today will be about what is menopause, just an overview, and I'll just talk about the symptoms of menopause and finally what we can do about menopause, or do we need to do anything at all? Okay, so I know most of you are probably in your 40s, but menopause is a little bit later in your life, but it's a perfectly natural life event, a bit like puberty. I mean, we all kind of went through it at about 12 to 14 years old. And similarly, menopause happens around the age of 45 to 55. Unfortunately, sometimes menopause can occur very early in some women. Often it's either because of surgery or some form of cancer, chemotherapy, radiotherapy. And then there's also a condition called premature ovarian failure. And in these ladies, unfortunately, menopause happens earlier, before the age of 45, and it has its own consequences. I don't have time to kind of go into early menopause too much, but if there are any questions on that, I'll be very happy to address them later. I also want to talk about the perimenopause. Perimenopause, peri meaning around the time of menopause, and it's known as the menopause transition. And this actually happens several years before the actual cessation of periods or menopause. And often symptoms start in the 40s. So maybe a few of you may be actually experiencing some of these symptoms. Now, as I mentioned earlier, menopause is a perfectly natural event. And the definition of menopause, and this is mainly for medical reasons, because we just want to define it. Doctors like to kind of have a definition for things. And the definition is a woman who has not undergone a hysterectomy, meaning has her womb intact, defined as having undergone menopause if her periods stop for 12 months, 12 consecutive months. So it means for 12 whole months, you don't get a period, it's possible that you could be in menopause. Okay, in pregnancy, it's 9 months. So we're not talking about that, okay? And as mentioned, the average age of menopause is between the age of 45 and 55. And I'm not sure if you can see my slide, the picture on the right. So what happens in the perimenopause and the menopausal time is that we have two very important hormones. One's called estrogen, the other one's called progesterone. And as we hit our 40s, these hormones start going down. And with this decrease in estrogen and progesterone, the eggs coming out, which is ovulation, starts becoming irregular. And the periods can become irregular, it can be heavier, it could be lighter. And then finally, when the estrogen levels are very, very low, you go into menopause. And that's when the periods totally stop. So here I've got a picture kind of trying to show you the drop in hormones. Okay, so the perimenopause is when the hormones slowly start going down. And at these times, the symptoms are very strong. And finally, when there's no periods, actually, when the hormones are very flat, symptoms of menopause actually get much better. Periods-wise, during the perimenopause, the periods can either be closer together, further apart, it could be heavier, lighter. So basically, there's a change as the level of hormones drop. And this is because there are two different hormones and then they become imbalanced. And with the imbalance, you kind of have periods either getting heavier or lighter. And then finally, you start having additional symptoms as well. And I'll just go through that. Okay, so menstrual pattern. What is to be expected? Periods can become lighter or heavier, and the cycles can become longer. Okay, and that is quite normal. But what is not normal is excessively heavy menstrual periods, okay? Menstrual bleeding lasting for more than 7 days, or very frequent, less than every 3 weeks you're getting a period. And the periods are very heavy. You're having pieces of blood or clots in your, during your periods, or there's any spotting or bleeding in between your periods, or after sexual intercourse if you're having periods. Now, this is not normal. Okay, so if you are having any of these symptoms, you should go and see a doctor because you may need to be evaluated for other causes of abnormal bleeding. Okay, but if the periods are just getting lighter and lighter, the cycles get longer, it's probably that you're just going into perimenopause and then finally into menopause. So I think that's quite important. Okay, now what are the causes of irregular menstruation? Menopause, that's one. Premenopause. And then finally, don't forget pregnancy. Okay, you could still get pregnant in your 40s and late 40s, early 50s. I had a patient of mine who came in. She was 49 years old and she was pregnant. And we said, congratulations. And she said, no, I can't be pregnant. So I said, why? Because I got a granddaughter. How can, So this happens. So don't think you can't get pregnant during this perimenopausal period. So do remember to use contraception. Okay, and if you do miss a period, just go get a pregnancy test done, unless you're ligated or something like that, because we do get women who do get pregnant during the later years. And, it can be very hard on their bodies to actually go through the pregnancy because we do have more medical issues as we get older. Okay. So I just want to talk a little bit about the hormone estrogen. Now, everyone thinks that the hormone estrogen has to do with reproduction and having your periods and giving birth to babies and, all that. But actually, estrogen is a brain hormone. Okay, the precursor of estrogen is a hormone called FSH, follicular stimulating hormone. It actually comes from the pituitary gland, which is from the brain. So estrogen, in addition to a lot of effects on the body, also has a lot of effects on the brain. And women in our 30s, 20s, 30s, 40s, we are kind of like super women. We are able to work, we can run a family, we've got kids, we've got older folk to take care of. We can do a lot of things. And part of it is our hormones, and it helps us to kind of cope with life because, I think we are caregivers, we, have a nest, we have work, but as the hormone goes down, superwoman sometimes can't quite cope. And one of the earliest signs of feeling, hey, look, I'm not quite my usual self, So from becoming the multitasker who could do everything, sometimes we start having symptoms. Okay, and these are the acute symptoms that occur in menopause. I think all of us would probably be aware of hot flushes, feeling very hot. I think a lot of us may have friends or, aunts or mothers who've actually undergone these hot flushes. And that's the kind of common symptom that people talk about when they talk about menopause. But there are lots of other symptoms. Firstly, feelings of anxiety, feeling that, I can't quite cope. Things are, what I used to be able to do, now I can't do them anymore, things like that. Because partly it's hormonal changes, partly we're probably doing too many things, maybe. A lot of times you feel that I can't remember things. You get this foggy thinking, can't remember, where did I leave my keys? What had happened to me? These kind of feelings. Awareness of heartbeat. Okay, so we have a lot of times our hearts are beating, but we are not aware of it. But during this period when the hormones are kind of going up and down, we kind of feel our heartbeat. And this can be very worrying. And I have a lot of patients who come to me after being seen by a cardiologist. So they'll be seen by the heart doctor and then all the checks done, no heart problem. I think it's menopause, and then they come and see me. So this is very common. The hot flushes can also occur at night. And this leads to poor sleep, sweating at night, feeling very hot and uncomfortable. Unfortunately, we also experience weight gain. Majority of us put on weight. Of course, there are some ladies who just lose a lot of weight. And unfortunately, this weight gain is also central. We start gaining weight around our tummy, that they call menopause tummy. And that's unfortunately not very good for our health as well. And finally, body aches and pains. Now, this is extremely common in Asian women. in the West, hot flushes have been reported, but in the East, a lot of ladies actually complain, oh, my body aches all the time. I just feel very tired. So that's another very common complaint. Okay, so hot flushes. 3 out of 4 women experience hot flushes during the perimenopause to the menopausal time. Severity varies. Some women just feel a little bit warm and then that's it. As to others, it really affects them a lot and they can end up having problems with coping with work, with home, etc. And it can be quite disabling. Mostly resolves once the time of the hormones fully settle down, but it can be up to 5 to 10 years. So, but that's very rare. Majority of women, 1 to 2 years, once the periods settle, everything settles very nicely. Okay. Okay, so just want to talk a little bit about triggers of hot flashes. Stress is known to trigger. So, if you've got a lot of things going on, you're rushing here, got deadlines to clear, kids, giving trouble, etc., you experience the flushes more. And a lot of times when you're on holiday and you're relaxed, hey, my flushes have disappeared, hot spicy food. A lot of our Singaporean, tom yum soup, etc. After taking it, they can have a flush. And, I suppose as long as you understand, yes, I ate that and it's going to cause me a flush, there's nothing to worry about. That's fine, but it's better to avoid these things. Alcohol, caffeine, cigarette smoking, all of which, are things that we could try to adjust or decrease if you're having flushes. Hot weather, unfortunately, Singapore is very hot and this month has been terrible. So, a lot of women are experiencing more flushing. So how do you manage this? Number one, understand that you're having a hot flush and that's nothing terrible happening to you, because sometimes when you feel it, you wonder, oh no, what's happening? So educating and understanding what's happening. And then simple things like cooling yourself, taking cool drinks. A lot of women take showers, but it's probably not the best thing because it kind of does dry up your skin. Using loose fitting clothes, cotton, things like that. Relaxation, meditation. I think Dr. Chua may be discussing more and more about that, so I won't kind of go into more detail. Exercise, regular exercise really helps. And I find that a lot of my ladies who do very, very well tend to be, going for runs, just kind of intensive exercise. It does help, okay? And if you find it helps you, just exercise more. It, really makes a big difference. And of course, avoiding the triggers. Okay, so management of lifestyle of hot flushes. Again, as I mentioned, all the lifestyle factors. There are also certain herbal supplements and remedies that are available over the counter. A lot of women use black cohosh or estrosol, Remifemin. These are the commoner brands that are available. I mean, if it helps, great. Okay, but also some of them are known to have kind of slight irritation of the liver, because a lot of them actually do come out of the liver, they're metabolized in the liver. So, I mean, it's okay to take them, but then you might want to just check with your doctor and just make sure that it's an authentic product and it's okay, because a lot of them are over the counter. And finally, menopause hormone therapy can help manage hot flushes. I mean, it really does help, but it does have its own issues. So here is a kind of a slide showing how we would like to manage women with hot flushes. If the flushes are mild, and majority of the time, it's just mild flushes, you just have this sensation of heat, you don't sweat too much. A lot of times lifestyle management is all that's needed. And, kind of understanding what it is. This is a flush, you know what you're supposed to do, and it will go away with time. Okay, moderate flushing would be the sensation of heat with a lot of sweating, and but you're able to continue with activities, and then it kind of settles down. Lifestyle management and hormone therapy can be explored in this group of ladies. And of course, very severe, sensation of heat, excessive sweating, you're really unable to cope with work, with, your normal activities at home and things like that. Then, again, lifestyle measures plus also hormone therapy may be something that this lady may want to explore after weighing the pros and cons. And there are other non-hormonal treatments as well. Another common symptom is actually vaginal dryness. So remember, the estrogen is a hormone, and it does cause our skin to be dry, to be more moist. You know, when you're young, your skin is moist. As you get older, it gets drier. You know, so estrogen, the hormones are what's kind of making all this. You know, and additionally, the hormones of the helps to keep the vagina more moist. And unfortunately, when menopause happens, and with the long-term reduction of estrogen, there is dryness of the vagina, and unfortunately a lot of women have a sensation of having to run to the toilet very often. They kind of leak, and we call that urinary incontinence. There are treatments available, pelvic floor exercises. These can be done, and they're quite helpful. Lubricants and local estrogens can be used if the symptoms are severe. So do discuss this with your doctor and don't suffer in silence, because it can be quite debilitating. Long-term, so kind of the flushing, the weight gain, all that sensations, symptoms that I discussed were the short-term perimenopausal symptoms. I do want to talk a little bit about the long-term sequelae. Bone loss and osteoporosis. This is one of the common symptoms as we get older. And I think there was an entire session on osteoporosis last week, so I won't be going into detail on that because that's another whole topic. Unfortunately, we also start increasing in abdominal weight gain. That means you may be thin, but your tummy starts getting bigger. And I think a lot of, I think they call it middle-age spread or menopause tummy, that happens. Now, a lot of women are distressed by it, understandably, because aesthetically it doesn't look very good. But worse would be actually this abdominal obesity, which we call, does lead to medical problems. For example, diabetes is very, very closely related to it, as So what is happening as we get older is that our muscles are being replaced by fat. So our muscles start atrophying or reducing, and unfortunately fibrous tissue and fat is replacing this muscle. And slowly we start getting a condition called sarcopenia, meaning the muscles are not as strong as they used to be. So this is all normal aging, but it's not good, and you have to start making changes in your life so that you will keep yourself well and healthy. And of course, age-related changes, the eyesight, skin, etc., etc. Okay, which kind of partly aging, partly menopause. I mean, they both kind of go together. So, Okay, so the question is, what can we do about it? Okay, so number one is being aware that, you're either in perimenopause or in menopause. Make sure, understand about contraception during this period of time. Know that these sensations, these body changes are natural. Be kind to yourself. I mean, don't, kind of just take it a little bit easy. Remember that you're going through a change in the same way that when you were young, you went through puberty. There were a lot of kind of crazy changes that happen. Similarly, in menopause, there are some changes. So be kind to yourself, accept it. Look, I just need to take care of myself better. Okay, healthy diet. Okay, so make sure that you are taking foods that have a lot of calcium and vitamin D. You may need even supplementation at this point, because this is when the bones start, the body starts losing calcium and the bones start eroding. So remember to take care of yourself. Maintain a healthy weight. So if you are overweight at middle age, there has been a lot of studies to show that later in life, you're more likely to have medical problems. So, this is the time to be a bit more careful, exercise, get adequate sleep. Remember, with the flushing and all that, your sleep may not be so great. So, try to prioritize sleep, exercise, managing stress. If you smoke, stop smoking. Okay, so all the lifestyle behaviors that you should start thinking about. This is also the time that if you're above 40, you may want to get a health checkup done, check your blood pressure, check your blood sugar, cholesterol, etc., because that's when things start changing. And you should make your health a priority at this part of your life. And then I've just talked about the others already. So I'll just go into a few things because I really believe what we eat, the amount of exercise we do, our sleep and stress management in our midlife really makes a difference in how we manage ourselves as we get older. So I just want to spend a little bit more time on that because I've only been given 20 minutes, so I've got to stop soon. Okay, so start reducing your calories because a lot of women put on weight and then they keep saying, hey, but I haven't changed anything in the way I eat exactly the same thing, but my weight's going up. And they say, yeah, you're not 20 anymore. You've got to start eating different. So start eating a little bit less, okay, about 200 calories less, and eat nutrient rich foods. Okay, increase your fresh vegetables and fruits, increase fiber rich foods, increase your whole grain, and increase healthy fats. And I tell all my patients, stop eating crap, okay? And crap is simple carbohydrates, like things that, like white, go for whole grain, whole meal, refined sugars, aerated drinks, Coke, Pepsi, at 40 plus, these are things that you should just throw out of here. And processed foods, unfortunately, our world is full of processed foods, and this makes a big difference in our health. So start being more mindful. And your diet should look like what is on the right. Lots of greens, fish, whole grain. This makes such a difference, okay, versus McDonald's and Pizza Hut and, a lot of fried hawker food. Okay, exercise, very, very important. And there are 3 parts of exercise: aerobic fitness, like walking, running, swimming, etc. Strength training, because remember I talked about sarcopenia, our muscles need to be building up. And balance exercises so that we don't fall, we have good balance, and we are able to actually carry on with life. And it is so important. Okay, sleep. Okay, I think Dr. Chua may talk more about sleep, but what I want to say is that sleep is different when you're young versus as you get older. So as we get older, we go into less deep sleep. So a baby can just sleep through anything. A teenager can sleep through an earthquake. But once you hit your 40s and 50s, our sleep is very light, very easy to wake up. So you do need a quiet, peaceful room to sleep in, and prioritize your sleep. Please don't spend, until 2 in the morning kind of watching Korean dramas and then kind of deciding to go to bed then. Take care of your sleep. It's really very important for your brain. And of course, management of stress. And I think Dr. Chua will discuss that further. So I won't go into much detail, but very, very important. So what you eat, the exercise you do, your sleep and stress management. 4 pillars. If you can kind of get that right, most of the time you're okay. Okay, so in summary, menopause is a normal life transition. Most women cope with just changes with lifestyle changes. I mean, some women have no problems through menopause. A lot of women just a mild kind of disruption, and they do quite well with just lifestyle changes. Ensure you're getting adequate calcium and vitamin D in your diet. A healthy diet, regular exercise, treatment, stress management, and sleep optimization. I've kind of gone through that already. And finally, hormone replacement therapy may be necessary for selected individuals. Okay. And does it matter? Does menopause matter? I think it does, because, menopause happens in your 50s, and it's likely the average Singaporean woman lives until 83, 84, and this was in 2017. So it's likely that maybe 30 to 40% of you may even live to be 100. Okay, whenever I tell my patients, hey, you're going to live to be 100, they go, oh my gosh, that'll be terrible. Oh no, I don't want to. And a lot of it is because we view aging as a very difficult, very physically challenging time, but it doesn't need to be that. Okay, and the changes you make in midlife is going to affect what happens to you in your 80s. And I think Dingsi will be able to tell us a little bit about that. And finally, this is my last slide, and I just want to put down the concept of live long, die short. I think it's a very Japanese traditional thinking that what all of us would like to do actually is to live well, live well, live well, live well, live well, and then just one day just die in our sleep at about 100, and that'll be perfect, right? But unfortunately, a lot of times it is at 50 to 60, we start getting problems, and then it's a slow decline down, and so we don't want that. So midlife, menopause is a very, very important time to start making changes in ourselves. And I wish all of you to live long, die short. Okay, so I'm going to end my talk here, and I'll be very happy to take questions later. Thank you very much.
Thank you so much, Dr. Rushini. That was absolutely amazing. I think there is hardly a corner that you have not covered. So thank you so much. Please, I want to remind everybody we have a couple questions already, but if you have any questions for any of the panelists, or if you'd like me to present it to the panelists as a whole or some as a discussion point, please feel free to write it in the chat or the Q&A. We're more than happy to talk about it. I'm going to pass now to Dr. Chua, who will talk a little bit more. Thank you so much, Dr. Chua.
Morning, everybody. I'm Dr. Chua. I'm also from KK, and I am a psychiatrist. So as you know, KK is a hospital where we see both women and children, and I am a women psychiatrist. So again, related to what KK helps women with, I see a lot of pregnancy-related cases, but of course, because KK also sees women undergoing menopause or women undergoing treatment for gynae cancers, so we do also see and support women with these conditions. It's an absolute pleasure to be here today, and thank you for sharing your Saturday morning with us. Okay, I have titled my talk today, Mental Health in Middle Life, because I think that this is a really important part of women's life cycles that tends to get, unfortunately, a little bit overlooked. I'm going to start by sharing a bit about what I see on my side of my table. Okay, so this I'm going to start with the problems that people come to see me for, which hopefully is not something that a large proportion of you here today will have to go through. But starting from there will allow us to broaden out into subtopics that are perhaps applicable to hopefully all of us. I love showing pictures of spectrums when I give talks about mental health, because it is a spectrum, isn't it? I mean, mental health, emotions are basically very subjective, very personal things, and they don't intrinsically come in black and white. No, they come in spectrums and ranges and things like that. And sometimes it can be quite difficult to tell for yourself, am I having a bad day? Am I okay? Or am I depressed? Or am I becoming depressed? And indeed, this is a question that many of my patients, when they come to see me for the first couple of times, they do ask. So as Dr. Rushini says, doctors do like to define things. So I'm going to start with defining things first, and then going more into the gray areas. Now, these are a list of very common mental health or emotional symptoms that my patients will bring to me when they first see me. So very often they will say that they've been feeling not themselves. And quite often, feeling not themselves would mean feeling sad, feeling down. Very often it might mean feeling anxious, much more than they would expect. Or sometimes it's anger and irritability. So sometimes they're getting really explosive and touchy about things. And sadness, anxiety, irritability. Yes, they are simple words, but if you experience them, they can change your lives drastically. Because in terms of interpersonal relationships, how you function, how you work, how you take care of your family, all of these things can be affected by your emotions. And of course, women who come to see me, they will often have symptoms that are causing them distress and discomfort. For example, they may not be sleeping so well. There may be a lot of appetite changes. They may be feeling really tired and unable to function in their usual ways. This is just the physical side of things, because inside their minds, people can have symptoms that can be actually quite debilitating. So if, for example, if a person has persistently negative thoughts. So if they are very prone to blame themselves for things that have gone wrong, to kind of accuse themselves of being lousy or stupid or inadequate, which is something very, very commonly seen, it counts as a symptom because it causes a lot of distress and it really can impede how we function. So when I see patients in my clinic, here is how I try to tell whether a symptom is just a normal experience that will pass with time versus is this something that we really need to sit down and look at together. I ask the patient and we find out through dialogue, are the symptoms that you are experiencing, are they excessive? Are they much more, than one would expect, given your situation? Are they persistent? So if someone feels sad for a few hours and, by the next day they're fine, I'll be like, okay, there's nothing I can really do for you. But if the symptoms are persistent in that this is how they feel day in, day out, whole day, every day for 1 week, 2 weeks, 3 weeks, 4 weeks, that becomes a problem that we do need to address. And as I've said a couple of times already, functioning is something that we also want to look at in terms of how serious a possible symptom is. And also, are people around you getting worried about how you're feeling and how you're behaving? So this brings us to a few common conditions. I will tell you that for each condition, we could possibly spend an entire lecture for each condition, but I'm not going to do that to you. So what I'm going to offer today is a little bit of a cheat sheet about what some common symptoms are of these common conditions. So I will begin with major depressive disorder because everybody has heard of depression, but major depression is when the symptoms of low mood are so bad, are so persistent that they really affect the way that one lives life. So clearly, if somebody has major depression, we would expect them to be feeling quite down and negative and finding it very hard to enjoy things, even if their lives are going okay. There will also be physical symptoms like changes in sleep, appetite, energy. And in terms of the internal, what's going on in the heads, a lot of things usually go on in the heads for people who are suffering major depression. It's a lot of negativity, self-blaming, and sometimes if it's so strong, people might get suicidal thoughts. Not because they enjoy making life difficult for their family, but because what they're going through is so difficult that their minds just instinctively is looking for some way to escape the current situation. So that's why people who are very depressed or very anxious may have thoughts of suicide, not because they want to, but because they are suffering that much. There is a local study called the Singapore Mental Health Study, which shows that about 5.8% of Singaporeans might have a major depressive disorder. Unfortunately, it is twice as common in women. It may not it may or may not be that women are more prone. It may also be that women are the ones who are more likely to seek help, for example. I'm sure we all know a man or two in our lives who might have difficulty talking about their emotions compared with the women that we do know. There are some risk factors that increase the risk of major depressive disorder, which is having had it in the past, or if there's a lot of people in the family who's had it. The duration of major depressive disorder that I, as a psychiatrist, look out for is if a person feels this way every day, day in, day out, for at least 2 weeks. So that is the clinical definition of a major depressive disorder. Moving on from depression to anxiety. Now, there are many, many kinds of anxiety disorders, including things like phobias, OCD, PTSD. So as I say these names, I'm sure you can imagine that, yes, all of these conditions are associated with anxiety, but perhaps the most common one I see in my clinic in KK is probably generalized anxiety disorder. This is something that is perhaps a little bit harder to talk about. It's not so sexy as PTSD. It's not so sensational and things. Rather, it's something that, someone who has GAD, generalized anxiety disorder, just feels anxious about everything all the time, and that is a really difficult and exhausting way to feel. The clinical duration that we look for is 6 months. And you can imagine that if you live every day in a state of anxiety, how exhausting, how wearing that must be, and how difficult it must be to be able to enjoy your life. So a person with GAD would be worrying about lots of things. And because the worry is so much, it takes a toll on their bodies as well. They may feel very tense, tremulous, have difficulty breathing, have palpitations, be very restless. So this is a person who is suffering both physically and emotionally, and may find it quite hard to actually verbalize exactly what are they so worried about. Family members tend to get a bit irritated with such patients because they'll be like, what is your problem? Just stop thinking so much. But I will tell you, it's much easier said than done to just stop worrying. Okay. This is another very common type of presentation we see in our clinics. It's called an adjustment disorder. This is perhaps one of the easiest conditions to understand as a concept because it simply means that when something really stressful has happened in our lives, the adjustment disorder is the emotional reaction that springs up in reaction to the stressor. So for example, it could be due to a marital breakup. It could be due to losses, like, if someone has lost a job, for example, and is in financial straits and they feel really guilty, they can't provide for their family. So something has happened in their life, something has happened to them, a toxic workplace environment, many possible things. And the emotional reactions are because of this stressor. And it becomes a disorder when the emotional reaction is rather stronger than one would expect. So for example, to the extent that the person is like very despondent, cannot sleep, starting to have difficulty functioning, that sort of thing. One more disorder, I think this is the last specific disorder I want to share with you, is something called insomnia disorder. And this in particular is a disorder that I would see quite commonly in referrals that Dr. Rukshini would send to me, for example, and her colleagues. An insomnia disorder is, we would consider that somebody has an insomnia disorder having a rather long-term problem sleeping. And the gauge that we use is problem sleeping for at least 3 nights per week for more than 3 months. So again, this is quite a protracted period, and you can probably imagine that somebody who indeed does fulfill this symptom criteria is probably like really tired and quite cranky and quite tired out. So this is something that we quite often see. Insomnia disorder, quite interestingly, it may happen even if a person is not particularly depressed or anxious. Yeah. So these are some common conditions that I would look out for in my clinic, and these are, I would say that these are the conditions that I would more frequently have to handle. Okay, so zooming out into perhaps a more focused aspect of what we are all here about today, and which is considering the timeline in a woman's life. So I like this picture because it shows the other way around from what we commonly see. Okay, so what we see first is the woman who is depicted as having gone through menopause. And then the second picture is somebody who depicts perimenopause, which we know that is an experience that starts happening in the 40s usually. And we know that all this is preceded by younger life, the premenopausal type of the time of life. I'm also going to talk a little bit about hormones, and I swear, okay, Dr. Rukshini and I did not collaborate on our slides, but I was kind of smiling throughout her presentation because there was just so much synchrony, and I believe and I suspect that the same might happen when Lindsay comes on as well. So Dr. Rukshini shared that estrogen is a brain hormone, and here's a graph to kind of illustrate how true that is. Yes, estrogen and yes, progesterone, they do have lots of effects on our gynae systems, but they also do have some effect on this chemical called serotonin, which you may have heard of. Serotonin is the main neurotransmitter, i.e. the chemical that works in the brain, that helps to govern our moods. So when we give medications for patients with severe depression or anxiety, the medication generally is to target serotonin. By and large, serotonin, when the level of activity of serotonin in our brains is low, that is when we become more prone to having mood problems such as low mood, sadness, anger, and anxiety, which are the 3 main groups of negative emotions we covered earlier on. And if you look at the lines on this thing, okay, I hope you can see my pointer. Okay, the green line is the female hormones. It's just it's a rough pictorial representation, so it's a bit simplified, but the idea is there. So this solid green line is estrogen, dotted blue line is progesterone. And as we go through our monthly cycles, estrogen and progesterone, they go through ups and downs to help our uteri do what they need to do. And as these hormones rise and fall, actually, right, if one were to look at the serotonin levels of activity in our brains, the pattern is not dissimilar. Okay, you will see that the orange line depicting serotonin activity actually is quite analogous to what the female hormones are doing. And once they dip below a critical level, that is when we might be more prone to negative mood states. And this is actually a really good pictorial, graphical representation of why some of us may be prone to premenstrual kind of symptoms. you know. So PMS is something that we would probably all have heard of just casually. And indeed, you know, there is actually a condition called PMDD, premenstrual dysphoric disorder, for those who have it more severely, you know, and it is something that we can also help with. It's amazing what all these little chemicals can do in our lives. And here's another graph, okay, also giving, also very analogous to what Dr. Roshni has shared, okay. So this is more to show hormonal fluctuations of estrogen and progesterone over our lifetimes. Again, very simplified, but what I wanted to show was that, okay, two things: estrogen, purple line, and progesterone, dotted orange line, okay. So as we go from our fertility years into post-menopause, the levels of both hormones settle, okay, so they become lower and they become settled, well and good. But en route, there is this portion in our lives when the hormones are literally up and down. In the midst of decreasing, there is a lot of irregularity and there is a lot of ups and downs. And now that you know how estrogen and progesterone can influence the serotonin activity in our brains, which then helps to govern our emotions, I think that this graph is quite a nice explanation of why women might be a bit more prone to emotional at a certain time of life. Again, you would be familiar with the common symptoms of perimenopause by now, but I wanted to introduce a possibly emotional angle to these symptoms. So symptoms like hot flashes, trouble sleeping, vaginal dryness, we know about these now, okay. Part of these symptoms include mood swings because, okay, we've just gone through the hormonal graphs. I think we understand this a little bit better. But sometimes when women experience the other physical symptoms related to perimenopause, sometimes I think they might wonder if, oh, am I developing some kind of emotional health problem, some kind of mental health problem? So for example, changes in libido, vaginal dryness might, you know, contribute to, for example, feeling less interested in sex, as would the decreasing hormones. And sometimes, I mean, I have encountered patients who have asked, does this mean I'm becoming depressed? Does this mean I'm developing problems in my marital relationship? Brain fog, you've heard about as well. And because someone who is very depressed, right, yes, they might indeed have problems thinking because in general, our systems are not functioning so well when we're feeling down. So somebody who experiences brain fog, insomnia, you know, changes in libido, they might wonder, am I becoming depressed? Or even, am I becoming demented? Am I losing my ability to think and to rationalize? So this is quite scary if you're going through this and having these thoughts. And if you consider symptoms such as urinary symptoms, you know, because urinary symptoms, there's also an overlap with anxiety. Dr. Rukshini shared that some people might present with palpitations during the perimenopausal time, and urinary symptoms can also come up. The difficult thing is that palpitations and urinary symptoms can also be seen when somebody is anxious. I mean, if you can imagine feeling anxious, sometimes you just need to go to the toilet, you know. So it calls to mind, you know, this overlap. And because I feel this way physically, could I then have this mental health problem? So all in all, the perimenopausal time is a period in life where a lot of things are happening internally, which might create questions in our minds about how well we really are. Sometimes actually it's okay. Sometimes it's just a passing phase and it will settle. But sometimes it might be an indicator of something else. And that's why we are here, to help to talk about it, to help to sort things out. Here are some reasons that I have learned across the years from my perimenopausal patients about why they might be experiencing mental health or emotional issues in addition to the hormonal changes. One thing is the reaction to the physical symptoms, because they can be very unpleasant to live with. On my side of things, children anymore, even if I want them to happen. And what does that mean for me? It means that I'm getting older. Okay, now I'm 45, I'm going to be 50, 55, 60 at some point in time. And that's something I can't even imagine now, but I have to think about it because it's going to happen. You know, it's happening to me. I'm aging. When we are young, we tend to think we're invincible, we'll never get old, but this is not a fact. You know, we will all get old. And here is the fact right in front of you. And sometimes, at this time of life is when people around you are maturing or changing or growing up too. Your kids might be getting big and getting ready to go to university, and it's like, oh, my baby is going off to study in some other country. That's a huge change. And sometimes there's changes at work too. At this kind of age, we may get promoted, we may be having to take care of our juniors, and we might start thinking about how we're going to retire. So again, so many changes. In the past year, especially, we've heard the words new normal so many times. But coming to terms with a new normal is something that all of us women do have to come to grips with as we pass through the times of our lives. Here, though, let me share a little bit of pop psychology, okay? So this is called the U curve of happiness, okay? And then I thought it was quite interesting because the idea behind this piece of pop psychology is that it's very simple, So basically, huge populations were surveyed, across various ages about how satisfied they were with their lives. So this is not unique to women. This is men and women, young and old, everybody. And the interesting thing was that across many situations, for example, across a range of countries, across a range of decades, this kind of sprang anywhere from the 1970s to the current age. People tended to have a pattern of happiness throughout life, So why they call it the U curve of happiness is that when people hit the 40s and 50s around this time, this tended to be the time when people were least happy with their lives, And I don't know about you, I'm kind of approaching the you part, So I was like, oh my goodness, what does that mean? Okay. So I thought about it and I thought that, well, okay, for women, yeah, we can talk about hormones, life changes, blah, blah, blah. But perhaps, perhaps this might be more of a universal phenomenon than we realize. Because I think it's at this sort of age when we start reflecting about our lives and taking stock, and seeing what we've achieved, what we've not achieved, how different we are. And then we notice, wow, white hair, wow, wrinkles, So all of this, I think they can accumulate and make us realize our essential vulnerability, that we are not invincible, that we're going to die someday, and what have we achieved in the time that we've had so far. So I think sometimes it can be quite existential. Okay. So that's the scary news. The good news is that by and large, people tend to swing back. That this time tends to be followed by a period of acceptance, and people accept, people come to terms with what their lives have been, and maybe they learn a bit more about life. Maybe they learn to let go of the negativity and some unnecessary ambitions, and then after that, people do tend to get happier. And if you look at the second half of this graph, right, in many cases, people who are 96 are happier than when they were 16. And I think that is such a marvelous piece of news. It almost makes me wish that, wow, okay, I kind of wish that I knew what it would feel like to get there. And it gives me something to look forward to. So, in a sense, even though this is a bit of a scary piece of news for me right now, it also gives me hope about what to expect in the future. Yeah, I thought this was a fun piece of, thing to share. Okay. I only have one single slide on psychotropic medication because I do not want to really get into details here. But by and large, right, I would categorize psychotropic medication, i.e. the kind of medication that I prescribe, as two categories. One, to provide short-term symptomatic relief. For example, if someone's having trouble sleeping, or if they're prone to outbursts of anxiety or anger during the daytime. So short-term medications would basically, take effect for a few hours and then they would wash out. So you have sedating things like benzodiazepines, sometimes antihistamines. The second category is what I call therapeutic. So usually it's patients with more severe cases of depression or anxiety who would need to take the second type of medications. And it's important to know the difference because the second type of medications is what I would ask somebody to take every single day for at least a few months, because they would need that level of medication to help raise back the serotonin activity levels so that they, once again, learn what it is like to feel emotionally healthy. And that's literally all I want to say about medication today, unless somebody asks me some questions. Okay, broadening out into what we all can do to take care of our emotional health a bit better. Okay, Some self-care measures would include things like sleep hygiene and learning teaching ourselves how to relax ourselves. Okay, so starting with sleep hygiene, which is the pictorial on the left, a lot of us have trouble sleeping. And before we turn to medications, there's a lot of things that we can look at to make sure that we are not sabotaging ourselves and our ability to sleep, especially since we know that with age, our ability to enter deep sleep becomes less and less. So it's really important to be kind to ourselves and develop healthy practices such as, something simple as avoiding caffeine, after a certain time in the day so that we don't sabotage our own sleep by taking too much coffee. One little fact I remember reading in my medical textbooks all those years ago was that caffeine can last in our systems anywhere from 6 to 9 hours. So after I read that fact, I told myself, no coffee after noontime, And I think that things like this, it's a helpful little tip for ourselves to make sure that we get the rest that we need. Progressive muscle relaxation is something that I like to teach my patients with anxiety issues, because when we get anxious, we tend to just curl up and tense and everything. And when our bodies tense and they get achy and everything, it kind of feeds into a vicious cycle, and that makes our mentality feel a little bit worse as well. So a progressive muscle relaxation is an exercise that we can all do, to develop more awareness of how tense we are. And then basically what it means is that we go through our bodies from head to toe literally, and we mentally focus on our forehead, our eyes, our cheeks, our lips, so on and so forth, making sure that usually what the relaxation will do is when I focus on my forehead, right, what I do first is I purposely tense it up, okay, and then I relax it, and then similarly going down, helps us develop. Also is a time for us to do something nice for ourselves, which in return creates a virtuous cycle. We take care of ourselves and we kind of making ourselves relax and getting rid of the anxiety for that time. I wanted to share a little bit about the therapies that we use, because I think that therapies, even though they come with awfully long names, actually they also come with a lot of very sensible, techniques and angles of looking at things that can be very helpful. Cognitive behavioral therapy is something that we do teach. And the rough concept is that, when something happens, right, we will react with thoughts, with emotions, leading on to behaviors. Okay, what do I mean? Okay, so let's say the situation, and we will compare two people here, Connor and Elliot. Let's say both Connor and Elliot both call a friend who doesn't answer the phone. So Connor, let's look at his cognitive processes, So my friend doesn't answer the phone. Connor's thought is, okay, so they're busy, maybe we can talk again later. So since this is Connor's thought, right, it's a very neutral thought, and it's more about them, it's not about me, and no big deal. I'll just try and call my friend a little bit later. Now let's look at Elliot's thought processes. Let's say Elliot thinks my friend is not picking up the phone because they want to avoid me, because they think I am a weirdo. If he has such a thought, right, he's going to feel sad and hurt, and he's probably going to want to avoid the friend who didn't pick up his phone. Okay, so this little example shows us how much difference our thoughts and our angles of approach to a given situation can affect us. And this is actually quite an important part of stress management, being aware of how we look at certain things and seeing whether there's alternative and more positive approaches that we can apply to a given situation. We might think more like Elliot, oh, it's because I'm such a weirdo, it's because I'm horrible kind of thing, because of these things called cognitive distortions. Cognitive distortions are things that we all have to some extent, So here are some examples. You might identify with one or two of them. So for example, overgeneralization. So supposing, someone who is giving a speech, and then they reflect back and say, oh, I didn't do so well in that talk. I felt so awkward. And then they overgeneralize. This means I'm an awkward person. I suck. I'm a lousy speaker. So from one event kind of blows up into, okay, I am this kind of person. I am lousy. I suck kind of thing. So this is an example of overgeneralization. Personalization may be another one. You witness something that is a bit upsetting and you kind of think that, oh, it must be because of something that I did, So mom looks upset, it must be me, I must have upset her. When actually, in fact, anything else could have upset her, So there are many possible cognitive distortions that we as human beings, do have to some extent. And it's awareness of our own personal cognitive distortions that can potentially lead to change. These are the closing slides already, okay? So these are just little things that we could possibly incorporate in our lives. I know I do. Sometimes I find these components of therapy personally quite helpful as well. So another kind of therapy that I quite like is called acceptance and commitment therapy. So this is a kind of therapy in which the therapist will go through with the patient. Yes, sometimes there's negative feelings, but instead of like avoiding them or pretending that they're not there or trying to run away all the time, one possible approach is to recognize them and learn to sit with them. So for example, someone who has an anxiety disorder, for example, they could choose to, once the anxiety feelings come, choose to go, no, 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 I cannot be anxious. I must be calm. I must be, I must be happy. Sure, they can react like that. Or they could learn to tell themselves, here are the anxiety feelings. Yes, they're happening again. Fine. I choose not to struggle with them. I don't like them, but I'm not going to fight with them. So this is an alternative approach to a negative emotion that we experience. So it's quite interesting because it's not calling anxiety bad or trying to get rid of it, but it's the process of learning to sit with something negative and being able to almost embrace it, to just sit with it and accept it. And conversely, over time, right, you might find that the ability to sit with the anxiety makes the patient feel that I don't need to be so afraid of my anxiety anymore. And then suddenly you'll find that over time, the patient does become less anxious. So I thought this was quite an interesting angle to a therapy that, I don't necessarily have to experience anxiety disorder myself in order to benefit from concepts like this. One last concept I would like to share with you today is that of self-compassion. Okay, so again, it's a way of self-care, it's a way of being kind to ourselves. Self-compassion is something that we incorporate into many therapies, but here are three main components of it that I would just like to share with you in closing. Okay, so the first component is something that we call mindfulness, which is a term that you might have heard of off and on over the years. Okay, mindfulness is this ability for us to sit and observe our own thoughts and feelings. Okay, be they happy, be they sad, be they beautiful, or be they ugly. Mindfulness is a practice that allows us to, okay, I'm having this thought, I'm having this feeling, I will let it come, I will let it go. Okay, so again, you don't reject any particular feeling, even if you don't like it very much. Okay. Second component, self-kindness. So let's say somebody's in a state of mind where they're experiencing lots of negative thoughts and emotions. Supposing some of these thoughts and emotions get in the way of being able to function. Okay. I think we're very good at beating ourselves about something like that. So if we fail to accomplish a certain standard or objective, we tend to tell ourselves, oh, I'm so lousy, I'm stupid, I just can't do this. When I see a patient doing this, I like to ask them, supposing it wasn't yourself having these problems, supposing it was your best friend, would you tell your best friend, you're suffering, you're going through this because you're lousy, you're stupid, you're horrible? And my patient could go, no, no way would I tell my friend these things. And from this, I learned that we're oftentimes kinder to other people than we are to ourselves. So I think this is quite a nice reminder that, self-kindness is something that may not come naturally to us, but it's something that we can incorporate. And if we do incorporate it right, then it actually helps so much in helping us develop a more balanced view of ourselves. Third component of self-compassion is connectedness, by which I simply mean that we are never alone in experiencing these negative thoughts, emotions, and, being unable to function sometimes. Everybody has bad times in our lives. So we are not the suckiest person that we know. Everybody struggles sometimes. And remembering that we are not alone in this, everybody else has a similar experience can be very comforting. And it also encourages us to reach out to other people who are in need, which then feeds back to ourselves. I'm a helpful person, I help to support and care for my friends. Okay, my very last slide is just a little reminder that, even though the menopausal period can be difficult, it can be associated with a sense of loss. But the silver lining perhaps behind that is that this sense of loss means that you have something that, you would feel sad if it wasn't there anymore. So even though this can be a time of struggles, right, it's not the end of the world. Sometimes there is regret, sometimes there's a sense of loss, but actually, right, in actual fact, you're just in the middle of your life. There is the second half of your life left to go. And this is, basically this is a little reminder that we have one life, and how we experience it, how we choose to experience it is what makes us ourselves. Okay. I suspect I have gone over time, for which I apologize, Valerie, and I will pass it back to you. Thank you very much.
Thank you so much, Dr. Chua. That was absolutely amazing. We are so glad that you can touch on so many different areas, especially areas that we have not been able, a lot of people have not been given the opportunity to talk about with their clinician or with their friends, with their mentors, and then also just touching on areas that might be a little bit more sensitive to talk about. So this is something that it should be normalized, that should be talked about. And if anybody has any other questions, please feel free to put them in the chat. I'm collating them so that I can direct them to the panelists that can answer them. So we'll try to hit everything. Thank you all so much for questions. We are all anxiously awaiting you, Dincy. Last but certainly not least is Dincy. I'm gonna just pass it off to you. We're quite excited to hear what you have to say. And as soon as Dincy is done, we'll move into a short Q&A. So I'll just pass it right to you.
Hi, everybody. Now, just give me a little time to share with you about my background myself. I am 87 years old, and I belonged to the two-child family era in Singapore. When I was 28 years old, I delivered my first baby, and then 3 years later, at 31, I had my second child, and that was enough. Stop. And so my gynecologist was the late Professor Shears, and he put me on contraceptives from 31 right up to 50 on contraceptives. And so there was always a good supply of estrogen and progesterone in my body. When I got into 50, then I went on menopause hormone. And that was Prampac-C was the one all the way into the 60s. And in the 60s, I was on Livia. Until 67, I stopped hormone therapy altogether. And that was a time raloxifene came into the market for bone health. So my gynae doctor then said to me, Dincy, let's take you off of hormone therapy, but I put you on raloxifene to keep your bone healthy. So that went on. So actually, I really stopped menstruation at 67 years of age. And I must say, I really enjoyed having all that estrogen in my body. Like Dr. Chua said, estrogen is good for the brain. Yes, I believe so. And so I really enjoy that. And when I was 62, I was invited to set up the menopause support group at the KK Hospital. And at that time, a year before that, Professor Day Boon Ling, the pioneer menopause management gynecologist, opened the first menopause clinic at KK Hospital. And he invited me to set up the menopause support group, and we launched a hotline. Whoa, there were so many calls. And it was really exciting time for me and a few volunteers. We worked together. So from those hotline calls, we received all those impossible questions, unreasonable questions, I call them. Today, I compile them into the myth of menopause. So let me mention specifically 7 of them. Number 1, a woman will call through and said to me, and crying, and said, I'm only in my 40s. And I have stopped the menstruation altogether, and I feel very unhappy. I said, why are you unhappy about it? He said, because that means at 40, I'm growing old very fast from now on. So that's one. And another woman would call in and said, I am in my 50s, but I'm still menopausing. I'm in my 50s, I'm not menopaused, but I'm still menstruating. I said, are you happy about it? He said, yeah, I'm very happy about it because I feel very young. Okay, and then another third woman will call in and say, I stopped my menstruation altogether. It's a few years already, but now my menstruation came back. So I feel very good. I said, why do you feel good? He said, I feel that I'm young again. So from these three women, I arrived at their association of menopause with aging. So your menopause, you're getting old. So I would always say to them, come and see me. Because I know I was not growing old, although my years were getting bigger. And so that was it. And the other people were calling and said to me, I have all these symptoms, la 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 la, you know, and especially mood swings. I can swing my mood inwardly, then I'm all alone. And in the morning, I wake up, I just feel the blues. And then my husband would talk to me. I wasn't paying attention, and my children were just getting ready to go to school. And so they're gone. I'm all alone by myself at home. I look into the mirror, I could see wrinkles on my face. I just felt so sad, and my tears would flow. And I feel inside me, I'm so alone, very alone. And some of them said, alone to such an extent, some of them even wanted to commit suicide. And in all my 25 years, the Menopause Support Group has been with us for 25 years. In all my 25 years counseling patients, I've lost one. Working with the psychiatrist, Dr. Pauline Singh at that time, this particular one, actually, I lost it. I walked with her through the whole year, and then she said to me, when Christmas comes, I'll bake you a fruit cake, because she was very good at baking. I said, okay, but I never ate the cake, because Dr. Pauline Singh called me up to tell me that she had jumped. And there was another one who called me out very late at night and said to me, Dingsy, I called to say goodbye to you. I said, where are you going to? Where are you going to? I thought she was going to Europe to sail down the Danube River and all that. She said, she kept quiet and she started crying. I said, oh, no. I said, wait. Now it's still very, very late at night, early in the morning. Just give me a few hours. I'll come over to see you. I want to see you before you say goodbye. And so she said, okay. So I quickly woke up Professor Day. I woke her up, I woke him up, told him about it, and he said to me, Dingsy, bring the patient in to see me right away. And so that case, we saved her. We brought her to see Dr. Prof Day, and Prof started on hormone therapy and all that, and she was doing great, absolutely great. And she was an artist, and she eventually had an art exhibition and invited me to the art exhibition. So these two cases, very interesting cases. So this is all about myth. So hormone therapy is very important. So when the woman told me about mood swings, inwardly very lonely, that I'm very concerned. And the person can talk about mood swing outwardly, swing outward towards other people, at home picking on the husband, get irritated with the teenage children, and they just made herself impossible at home. And the children would come back late just to avoid all this. And then outwardly again, if this woman is working and all her colleagues would just ostracize her because she got irritated, she would scold people and she would throw things around, she bing bang all around, and make herself very, very unpopular. And these women, when they call me up to talk to me about it, I would say, well, see your doctor and put yourself and agree to understand that HRT and agree to go on HRT. And then that woman said to me, Dingsy, I have HRT in my hand. I said, wow, that's the best. Why did you not take it? If you took it in 10 days' time, you'll kick in, the effect will kick in, you'll be very good. You'll be in good control of yourself. He said, no, I don't want to take it. I said, why not? Because HRT, another myth, will give me breast cancer. So all these things, it's all myth. And let me just, so breast cancer, I said, no. So I had to talk to her to make her really understand that HRT would be very useful to her. And there will be, just let me get into my notes. So suddenly, so sorry. I lost. Okay. Okay, so much for all that one menopause. Oh yeah, And others will, another one would call through to say that weight gain. The person was putting a lot of weight, and the person blames menopause for helping her to put on weight. I said, no. And also change your body shape, like Dr. Chua was saying, and the pear shape becomes an apple shape, and the person was very miserable about the weight. So I would say, well, this is all about your lifestyle. It has nothing to do with menopause. And then another one would talk about vagina dryness. You know, I said, how do you know you have vagina dryness? He said, well, very painful at intercourse and low libido, like Dr. Chua was talking about. Low libido, it's all in the head, in the mind, you know. And so, but anyway, so the person would talk about refraining from sex. And then I said, well, that would not be very good for your husband. And then the patient would be talking about that this probably my sex life is over. So that's another myth. We can treat the vagina, we can get back to our ex again, you know. And there's another one would be talking about all these menopause concerns. I have a lot of questions, but I just think it's a taboo to talk about it. A taboo to talk about it. As now you're talking to me about menopause, and it's no taboo. Just open up and talk. And so I understood all these myths. This to me, they're myths of menopause. And if this woman is keeping on thinking like that, she is really battling through menopause. And yet menopause is such a natural thing, natural transition. And we just go through it. Most of us will go through menopause very smoothly. And so if you are that kind of woman who battles through menopause, I would encourage you to dispel all the myths I share with you. Menopause is not aging, HRT does not give you cancer, and your dry vagina doesn't mean that your sex life is over and all this and all that, you know. So dispel all these myths and be positive. And I would encourage you really to talk openly about menopause. And so, like, I love to talk to people about menopause. And so, like a beautiful butterfly, you rise up and you fly, and you enjoy the rest of your life to the fullest. So here ends my talk. So sorry for the interruption.
Thank you so much, Dincy. That was absolutely amazing. I think if anything, having these kind of open dialogue style conversations is really important. So thank you for not only talking about the myths and the things that women come to you about, but also talking about your own experience and tying that in. I think that that's extremely important to talking about menopause from a holistic perspective. So thank you so much. I would like to answer or to put a couple of questions to the panelists now. I want to go back to Dr. Rukshini real quick. We want to talk a little bit about diet. I'm going to collate two questions into one here, Dr. Rukshini. If you have any answer on a couple comments on traditional Chinese medicine, if there is a connection between the benefits of certain traditional Chinese medicine treatments, and then also somebody asked about soy as well. And if you could address whether or not that is a useful way to alleviate menopause symptoms, or if this is more of a myth, or if there is a special way that we need to look at each of these diet considerations as it relates to menopause symptoms.
Okay, thanks for the question. And these are some things that very commonly people do discuss. So there is this concept of phytoestrogens, meaning plant estrogen. So, we kind of did discuss that the issue would be actually this change in estrogen levels. And, as Dr. Chua also showed, estrogen does really make a difference in the mind as well as the flushing symptoms. So soy is thought to be a plant estrogen and has a very similar property. And it does help. Now, if you want to take soya products per se, you probably need to have like large quantities. I used to have a slide that says that you probably need to take like half a kilo of soya per day, which is not kind of practical. So there are a lot of soy-based products, one of them being Estrus soy. Actually, when you go into the market, you can find them. They're actually supplements. So not not as controlled as medication. So the main issue is not that soya doesn't work, but wherever you're buying it from would have the correct, what's labeled is what's in the product. That would be more of the issue. But yes, soya does tend to alleviate symptoms, especially the flushing. There are a fair amount of studies that show that probably 20 to 30% improvement of symptoms with soya or black cohosh. That's the kind of the supplements that have been tried. Evidence-based medicine, if you do these large RCTs, meaning randomized control trials, you may not make that much of a, it's still very controversial, but to most women, it's N equals 1, meaning if I take it and I'm feeling better, that's fine. We don't need a huge trial to kind of say that, yes, you can take it or not. So what I'd suggest is, yeah, maybe just try them. And a lot of times as a first line, we would give supplements of soya, and it helps. The other interesting fact that I'd like to point out is there is a theory that, remember I talked about hot flushes are more common in the West, or at least reported in the West. And this is thought to be maybe because of the diet, because there's not much soya type foods in the West. And in the East, especially in Japan, there's been a lot of studies published that, Japanese women, at least about 30 years ago, did not feel as much flushing as women of the in the West. So maybe the theory is that maybe they took more soya products. The other thing is diet-wise, red meats are thought to be anti-estrogens. So we don't know if it's because the animals have been injected with hormones, or if it's really, the red meat itself, but generally there is this issue, and yeah, it is worthwhile trying out soya and cutting down red meat. The second question on traditional Chinese medicine, I mean, I'm not a traditional Chinese medicine practitioner, so I can't give you like details, but I do have a lot of patients who are going through TCM. I mean, acupuncture has been studied with menopausal symptoms, and there is improvement. The traditional herbs, I'm not an expert in, but I do have a lot of patients who do take TCM and they feel better. So, it's worth exploring. Yeah.
Great. Interesting. Thank you so much, Dr. Rushini. And if any of the other panelists have any comments on those, please feel free. I do want to ask Dr. Chua a two-parter question. And I have to say, as you were going through your progressive muscle relaxation, I was imagining all of us kind of taking our brow and furrowing and then relaxing. I think probably everybody saw me going like this as well, but I really enjoy that type of advice, and it goes along with what our attendees are actually talking about as well. We're all looking for non-medication ways to either increase serotonin levels or increase other things that help us feel a little bit more balanced, a little bit more normal in our everyday lives. So whereas progressive muscle relaxation is one of them, can you talk about these meditation apps? If you've seen that this is effective in the women that you see, and then any other non-medical ways that have shown to specifically increase serotonin levels. We're all focused on these levels specifically because at this point in women's lives, we can recognize when they're lower and how that affects our everyday life.
Okay, thanks, Valerie. I'm going to talk about the meditation apps thing first. I think it depends on the individual. Okay, so I think for what I've seen is that for patients who like, taking time out and like focusing on how they feel, and they are able to concentrate on meditation. I mean, so right now there's actually a lot of apps that one could possibly try. A couple of them that my patients have mentioned, one is called Headspace, one is called Calm. These are more mindfulness-based therapies. And it can be very helpful if you are the kind of person who can do it, okay? Because I mean, for most of us, right, we experience all these emotions and we don't take the time and the space to focus on it. So for the proportion of us who respond to this, meditation apps can be extremely useful. And furthermore, much, 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 much cheaper than trying to find a therapist who would do something similar with you. The caveat is that there are some individuals for which meditation or meditation apps would not be such a good idea. One specific type of diagnosis would be those patients who have undergone trauma, for example. So if they've had a very if they've been affected by a very specific and very traumatizing type of abuse in their lives, sometimes meditation apps can just bring them back to that abuse time, and it can be very scary, especially if they're on their own because it's an app, right? And there's no like support immediately available should they get triggered or traumatized by focusing on it. And I suppose the other category at large is, I mean, there are some individuals who prefer not to focus on feelings or thinking about them. So when I talk to my patients in my clinic, most of them welcome conversation and they try to drag on extra time if we can, which, as you know, I get carried away and then my clinic assistant starts scolding me. But now and then I run into patients, when I start to ask them more questions about their emotions, they will start scolding me. They will ask me, why you talk so much? Why you want to ask so many questions? So from this, I know that there are some individuals that prefer not to focus on the internal processes, and I would not be recommending meditation apps for them so much. Yeah. The other question was about non-medical ways to raise serotonin levels. So there's been a lot of studies on this because as you can imagine, I mean, if you could take certain foods, you know, to treat depression, that would be so much more attractive than having to take a pill every day. And I think personally that there might be something to that, in that, yes, serotonin is a chemical in the body and we need to provide the body with sufficient building blocks to create the chemical. But in terms of the serotonin activity, it's not just down to how much protein and stuff that we take. It's also the body's processes of manufacturing the serotonin and also using it in an appropriate way to regulate our emotions. As far as serotonin is specifically concerned, I mean, like recommendations to make sure you have enough protein like salmon, turkey, like bananas even, because these foods contain a precursor called tryptophan, which which is needed in order for the body to make serotonin. But what I'm saying is that the manufacture of serotonin is just the first step. There are many steps after that that have nothing to do with, you know, the amount of salmon that you eat, for example. So some non-medication ways that the serotonin level can be raised, or the serotonin activity can be increased rather, is actually through means like, you know, self-care, or, you know, for those who needed psychological therapy. So those concepts that I shared with you earlier. So supposing a person has a lot of cognitive distortions that are creating more stress than they actually need to go through, if they are able to, you know, rectify or adjust some of these distortions so that they are not hard on themselves, actually in the long term, right, such therapy concepts can actually help to regulate the serotonin activity. And not just that, there are studies that show that psychological therapy, right, if it's for the right person and over a good length of time, it can even improve the brain metabolism. So I think that's an amazing thing.
That's great. That's really, really interesting. And I think the fact that there are studies on this as well is quite interesting. Dincy, do you have something to add? I think maybe you have something to add on serotonin levels.
Oh, yes. Serotonin, to me, is the happy ingredient in our body, and it is made in the brain. And we have two brains, actually. One brain is in the head. The other brain is in our large intestine, And that is a microbiome. And if I keep my microbiome in the intestine healthy, and this is the area the serotonin is made. The serotonin is made in the brain, which is situated in the large intestine. So there's something we can take to keep the microbiome very healthy, and that something is kefir, K-E-F-I-R. So we can make our own kefir. I drink a lot of kefir every day, you know, just to be aware of my serotonin, making serotonin in my large intestine, and I'll be always in a happy mood. And it does work because I make us, the kefir is about good bacteria. It's a fermented drinks. And so we increase a good number, about 80% or more good bacteria in our second brain, in our intestine. And we will have enough serotonin to keep us in a happy state of mind. And so drink kefir, K-E-F-I-R. I demonstrated making of kefir to my support groups. And so all our ladies are making kefir and drinking, and we all share about it. You know, it's really great. So get to Google KEFIR, learn to do kefir, and to increase your serotonin production. You'll be a happy, happy woman.
Thank you, Dinty.
Can I add about exercise as well? Because, you know, it really does help with relaxation. Exercise is actually very, very important as well. It helps with serotonin. It helps to kind of bring out that happy feeling. And even for things like brain fog, dementia and all that, it's actually very, very important, because also think about that aspect of improving of mood. So food, as Dr. Chua and Dingsi talked about, exercise, I think that's also very important. And I find that in my practice, a lot of times it's a bit of a vigorous exercise, because everyone keeps telling my patients talk about, oh, I said, do you exercise? Oh, I do housework. Housework's not exercise. Okay, no one enjoys, I mean, I don't know, there might be some people out there who enjoy it, but you know, so honestly, exercise is something that should be, I think, to a certain extent vigorous. So at least a brisk walk, a little bit of, you know, muscle building, it makes such a difference. Okay, and just think about that as well for serotonin production, and I think also for dementia prevention, because I think that's the thing that everyone's kind of a bit concerned.
I was going to say there are multiple benefits to proper exercise that, you know, gets your heart rate up a little bit. You get a little bit of sunshine. You can hear the birds. You're outside. So many benefits mentally, physically, emotionally. So thank you for adding that. I want to have maybe, I know we're coming up on time, but I would really love to do one more question. Really to all panelists, but I'd love if Dr. Chua and perhaps Dinsi as well, if she has some experience on this. What we're talking about and what attendees are interested in knowing more about is at this time in life when the hormones are quite, you know, what we would, you know, our bodies are doing what they're supposed to, but we feel off balance. We feel a little bit kind of out of it. We don't feel like we did in our 20s and 30s and 40s, but what does that look like in our work lives, in our home lives, and does that put us at a disadvantage? And then kind of part two, if this is true, if this kind of affects our personal relationships, our work relationships, managing so much, are these conversations being talked about with husbands and with family members, kind of as part of a whole? You know, how can we? Is this actually happening? And is it helpful? And what advice can you give women who are feeling maybe disadvantaged at this point in their life, in their work lives or in their home lives with their husbands and their friends and colleagues? I don't know. I'm going to open it up to the whole panel and see if anybody has a way of addressing that.
Can I just share a little bit? Because I do see a lot of, you know, like probably 50 to 60% of my patients would be in a similar situation. So by the time they come to see me in my clinic, they would have already gone through their primary care doctor. They've been talking to people, their friends, etc. And then finally they're seeing me. Probably about 10% of women bring their husbands along. And we find two types of husbands. One, some very, very concerned, very supportive, you know, and then you have another group that is terribly uncomfortable on their handphone, like Googling, I don't know what they're doing. I mean, the wife's there, the husband's behind her, and he is like, I don't want to be here, okay? But then you do have the very, very supportive husbands as well, who like kind of on their own have read up about it and they really feel for their wives. And I think really a very supportive family, you know, as in husbands, children. I think kids also tend to, because they are teenagers at that time, and they can be very judgmental. You know, some of them are. Sometimes you have daughters coming in with mothers who are very, very supportive. I've yet to see, I think I saw one son come in and he was very uncomfortable, but you know, it's definitely there. So I see very much on the family. And I do think a very supportive family would make a big difference, you know. Unfortunately, there is a lot of things going on in the family, and we do have a fair number of ladies who say, look, my husband's leaving me, I'm going through a divorce, my husband's having an affair, that kind of thing, and that definitely does bring things up. I do find that women who do take a short course, or who do decide to, after discussion, start on hormone therapy, tend to do fairly well. And I do think that hormone therapy has been villainized a lot after the WHI study, and but it does help women. And again, it's like any medication, needs to be given for a period of time to the appropriate person. So it's not like everybody should be on it, but at the same time, there are a lot of women suffering who are afraid, very, very afraid. I think Dingsi's also kind of shared that. Workplace, again, women do. I have had a few women who've actually said, look, I need to just quit my job, that happens as well. So I think Singapore that way is not as understanding as we could be. And I do agree that maybe there has to be more awareness of what can be done. There is a little bit going on about menopause in the workforce and the workplace. It's just that we've got to educate more people, because unfortunately it can become, oh no, she's menopausing, oh yeah, that's why she's behaving like that. Sometimes there can be a lot of unkindness during this. So as I think we've also talked about it, young people may think, oh, it's never going to happen to me, I'm never going to get old. That could be one attitude. Men may or may not be able to accept it. So if you're going to be having a workplace and the menopause, I think that's kind of going on in the West at the moment. But I'm just hoping that if we do bring it, we have to translate it and bring it in sensitively and not negatively.
Yes. Yeah, that's really great advice. I think this is something that we wish we could bring to certain organizations internally, and what they can do to support women during this time in their life from an internal perspective. Dr. Chua and Dinsi, I know that you may have one or two things to say. Keep some comments brief, because we want to hear from all of you, but we are running out of time. I don't want to take up everybody's Saturdays so much, but please share.
So I will share something that I saw on my Instagram feed just this morning, which I've been thinking about, which is that, I mean, it was just a statement, which is that one man in a room full of women is ecstatic. One woman in a room full of men is terrified. Okay, so I don't think things are quite as extreme as that in most cases, but I think that there is a difference in how men and women perceive one another. But the nice thing is that I think the world is right now quite ripe to consider changes, to this. And I would heartily echo Dr. Rukshini's what she said about involving men, educating them. So I do see women who bring men to their husbands to my clinic as well. And I do encourage it in situations where they want their husbands to learn more about their conditions. Not so much that I will tell the husband what is going on and tell them how to behave, no. But I want the husbands to witness for themselves how we talk about things like emotions, which is something that they may not actually have experienced before, and something like seeing it for themselves, seeing how such a conversation is had can be very helpful. And I think that this is why we have talks like this as well. So one thing that I would personally love to see in future talks is it were attended by not just women, but by men as well.
Yeah, absolutely. Dinsi, I know you have a few things to say as well.
Okay, there was this occasion, the doctor sent this woman to me and she was crying and her husband was with her. So the nurse asked me, Dinsi, do you mind if the husband sits in? I said, no, most welcome. So I did not know what I was in for. So the husband and wife came in and sat down, and she was still crying. So I gave her a box of tissue paper, let her calm down, and she stopped. So I said to her, why are you so sad? And she kept quiet. So I repeated again, and the husband was sitting in the corner. I wasn't looking at him. I just looked at her again. I repeated, why are you so sad that you need to cry and you can't stop crying? And then suddenly she burst out. She said, it's all his fault. All his fault. Then I never looked at the husband. I just still looking at her and said, what did she do to you? He said, well, this morning I knew I was coming for the appointment. I was ironing my clothing to change, and he came and wanted to have sex with me. And so we went to the bedroom and wasting my time. I felt so unhappy about it. And so she started crying again. So I just pat her on the hand and I said, don't cry. Your husband is a very loving person. Do you know why? I said, he did the right thing. Appointment can be a little bit late. You know, sexual activity, intercourse is the best exercise between husband and wife. I told her that. And the husband right away interjects, I told you it's the best exercise, you know? And so that was it. And then she quietened down. And so we talk about things and all that. And so then they finished, they got up, they held hands, and they were smiling and going out. The nurse came in and asked me, what did you say to them? And they came in crying, they walk out smiling. So I think it is very relevant to have husband coming in for counseling together. It is the best and the best. So this is the one case. One case. A good one, right? Good one.
Yeah, really good example. Yeah, these real life examples, I mean, they're just so helpful. Thank you so much, Dinzy.
I just hope that during this COVID time, everybody's staying at home. Husband is always staying at home. They get the intercourse thing going between husband and wife. It's a good time to keep on practicing.
Talk about happy hormones, right? Exactly.
Good one.
Thank you so much. I think I'm going to wrap it up. We're already 10 minutes over, and I do feel that we could probably talk forever and ever. Thank you, everyone, for your questions. Thank you, panelists, for your contributions, your the wise advice. I mean, honestly, we would all. It would take months, perhaps a year or two, to really gather all of this advice from our clinicians and from our colleagues. So thank you so much for just sharing everything that you've learned, everything that you have heard and experienced in your life during this hour and a half. We really appreciate it, and are certainly passionate about women's health, especially at this point in their lives. So I want to end on letting you know that there is one last webinar next week, the same time. Please feel free to use this QR code, sign up. We will have more of the discussions like we had today and that we've had the last 2 weeks. We like to keep it open. We like to hear what you want to talk about, and we like to really use the wisdom and knowledge of all of our panelists during these webinars. So the QR code is on your screen. I apologize if we weren't able to answer all these questions, but thank you so much for joining us. And thank you to Dr. Rushini, thank you to Dr. Chua, and thank you to Dinzy. And Access Health wants to thank Wings, of course, for all of your help and collaboration. We are absolutely loving this entire series. So thank you so much. Everybody have a wonderful rest of your Saturday.
Thank you, you too.
Thanks. Thank you.